Good afternoon, everyone. Thank you for joining us. It is right at 2 o'clock Eastern, so we're going to go ahead and get started. Thank you so much for joining us for today's presentation, PDPM Looking Back and Planning Ahead. Our presenter today is Maria Arellano, one of our senior healthcare specialists with PointRight Solutions. Before we get started, I know we have some people still joining, but before we get started, just a quick few housekeeping items. All attendees are on mute. If you have a question, you'll see a question box in your GoToWebinar meeting panel. Go ahead and type that in there, and we will be having a Q&A session at the end. But if you do have questions regarding audio or handouts, just go ahead and pop those in there, and we'll try to answer those along the way. And with that, I will hand it over to Maria so we can get started.
Great, thank you, Allison, and good afternoon, everyone. Thanks for joining me today as we take a look back over the last 9 months since the implementation of PDPM so that you can consider your strategy, planning ahead and looking forward. We know that you've had much higher priority issues to deal with lately. So we wanted to do some analysis or do the legwork for you and hopefully give you some clear areas where you might be able to focus some attention and reduce your risk for CMS scrutiny and compliance concerns. So if we look at the objectives today, I hope to help summarize some of the key insights into PDPM and point out to you areas where you might be at risk from a compliance standpoint. We'll talk about strategies to address any unfavorable trends or patterns in the data that might be occurring in your facilities as well. So, but it's interesting because, if we look at the data that we have so far from PDPM, we have to look at it through the lens of what's been happening. Right, if we, in Q4 of 2019, calendar year, the data might not be the best reflection of what's to come for PDPM because of that transition time, right? And there certainly was a fairly steep learning curve to PDPM for many folks. So, that we know that we have to understand that when we look at that data. And in Q1, which was going to be the first full quarter of some pretty solid data, we were all excited to kind of start looking at it. Well, then March hits, right? And so we really truly believe that there may be at least partial impact to some of that information in Q1 related to the COVID-19 pandemic. And then we look at Q2 data. And so now we have, and again, these are calendar quarters, Q2. We have the first full quarter, but it's completely been impacted by COVID-19 and the CMS waivers. So we really haven't had a normal opportunity to evaluate what we're seeing. But you know what, it is what it is, and there's still considerable value in taking a deeper dive into this data. And so, what I'll be sharing with you today is the national averages, and these are calculated from our national customer database that we've amassed a considerable sample size and certainly a statistically significant sample size as we process over 25,000 MDSs per day. And so we're able to really watch the patterns in these emerging trends to help identify potential problems early on. And so we thought we'd share them with you today. When we look at this information, it's important to look at what are we watching for, what is important that we as providers watch for, and what's CMS watching for, right? And so as you can imagine, there's so many different elements to consider when analyzing the PDPM data. But for today, I want to focus a deeper look in these 3 areas. What MDS coding pattern changes are we seeing? Some of the questions and the underlying questions that we all need to be watching for. Are these true changes in our system? True changes in our population of the types of patients we're taking care of? Are these improvements? So there is a result of the improvements in the assessment processes that we've implemented. Or, perhaps there may be evidence of gaming the system, right? And we know CMS is watching for that. So that's something that we too have to be watching for. We'll also be looking at areas of increased CMS scrutiny. What areas create that extra risk for us in terms of regulatory and then also compliance and potential areas of fraud. And then looking at potential missed opportunities, where we might have overlooked something. And so that really losing revenue that we were definitely deserved because the information was there to provide. So let's first take a deeper dive in the MDS coding pattern changes. First, I want to look at the nursing payment drivers. So let's look at this pre and post PDPM implementation. So in the first column, you can see that from July, August, and September, so this would have been fiscal year Q4 or calendar year Q3 of 2019. You start with extensive services. And then to the right, we're going to move to the post PDPM implementation quarters. And we now have 3 full quarters to look at. So you see in extensive services, in the coding of extensive services, you've seen just a slight, kind of a gradual increase over time until we hit calendar year Q2 of this year, the quarter we just finished. And I'm sure we're all sitting here thinking, not a surprise here, right? Certainly not unexpected, especially because isolation is coded in extensive services, right? So this makes sense for many folks. We did see an increase nationally here. Under depression, right? This again, pre-PDPM, we were capturing about 4.9% of the assessments had depression coded. Well, we're the very next quarter, jumping up in the very next quarter where we implemented PDPM, we see this doubling, 9.8%. So a pretty dramatic jump in coding, okay? And then in the subsequent quarter, obviously it continues on an upward trend. And then in this last quarter completed, just kind of gradually, pretty much staying about the same. So kind of leveling off. But again, you see this dramatic jump. So when you see those, and I think those should send up little red flags to us and say, okay, what changed? Well, we know the rate it's now a rate driver. And so this is something that CMS is certainly going to focus on, is why all of a sudden did we see a dramatic change in the population from quarter 3 of calendar year Q3 to calendar year Q4 in the facilities? Not likely, but we now know obviously the change in payment model might be incentivizing us. So CMS is going to be most likely targeting this, right? So again, we should be too. And then likely, along the same lines, restorative. Restorative, we certainly have not seen the dramatic increases across the board, as you saw in the other two, but just more of a slow increase and then stabilization here in the last 2 quarters. Okay, let's take a look at speech component in PDPM. Again, you see in the first column the pre-PDPM calculations, and again, these are the percent of assessments that have the code these particular areas. A cognitive impairment, here pre-PDPM, 13% of the MDSs coded with cognitive impairment, but yet another very dramatic jump in the first quarter of PDPM. And you see here the upward trend continues through the next 2 quarters. And here we are landing in the last completed quarter at over half of the assessments being submitted are showing cognitive impairment. And again, the important thing to look at this or to understand about this is the first level analysis here. And so we're seeing this, and these where we say, okay, we're seeing patterns and trends in the data, and it's potentially telling different stories. And so we have to understand why these things are happening. And so in a little bit, we'll go into some more strategies on deeper dive and root cause. Okay, let's move on to swallowing disorder. Pretty much the same story here. Very dramatic increase from the 4.7% of assessments in pre-PDPM and 15.7% in the first quarter since the start of PDPM. And again, the upward trend continues as you look to the right. In quarter one of 2020, calendar quarter one, 17.26. Nice little steady increase. And then we've kind of leveled off with just a slight downward tick in calendar year Q2 or April, May, June. Okay, and I want to make sure I qualify all of these with the, the fiscal year and the calendar year here, and make sure I call them out specifically. And then lastly, the mechanically altered diet has certainly been a much slower increase, but nevertheless an increase from 23.5% to nearly 31%. So definitely, certainly some areas. And if you think about it, these are two areas of the nursing and speech areas that were not heavily focused in the RUGS model. So that's why I wanted to, again, call out these 6 very specific payment drivers related to nursing and speech, because we need to, whenever we see these patterns, it's really important for us to be going, okay, red flag here. Can we explain this? Can we make it? Because again, we've heard very, very loud and clear from CMS that one of the main reasons why we switched from the RUGS model is because there were certainly some interesting incentives to focus and code in certain ways. And so they're going to be watching very, very closely at these kinds of things, okay? Next, let's turn to non-therapy ancillaries and take a look at what we're seeing nationally in terms of the distribution across the 6 case mix groups here. And, I displayed it this way, on purpose so that you could see these subtle changes month over month. And again, hopefully you have the ability to look at this same kind of breakdown in whatever system you use in terms of the PDPM insights that this information can provide. So on the left-hand side, the lower left-hand side, I gave you a little legend here to look at. And there we see the case mix groups and the NTA score range breakdowns or the cut points, okay? And then across the top, you'll see the case mix indices for each of the case mix groups. And this is a really important thing to understand and to look at. And so here I've broken down the first 2 quarters of calendar year 2020, and to see what we're seeing across the board. And again, this is the percent of assessments that we're seeing at the PointRight national average. Okay. And if you look, you really don't see any dramatic changes in percentages of assessments. However, when you look at the NTAs, it's important to consider even the small percentage changes can mean a change in the multiplier, which certainly can add up or detract. So you see, if I click here on NF, let's first look there. And this is the lowest case mix group that has a CMI of 0.72, so below 1. Okay, so in January, we're at 21.9% nationally. And so, but by April, it was kind of creeping up there to 20.1%, May 20.3, and excuse me, creeping down nationally, excuse me. And so what that means here is that the good news there is that means that the more were being assigned into the other categories that had a higher percentage or higher case mix index, right? So let's say they move to the NE, that would now be able to have 0.96 as your multiplier. Okay, again, so looking at some of these subtle changes can help us see what's going on in your facility. You can do the exact same thing with your facility or organizational data. Okay, let's look at here in the NB and the NC categories. Again, you see some subtle changes in NB, a little bit over 0.5% percentage point increase. And in NC, an increase of a little over 1.5%, right? So again, subtle changes. So again, perhaps, and again, more percent of assessments are landing in this category, which has the 1.8 case mix index. Okay. And lastly, here you see like an ND going from a 31.4 to a 32.6 nationally. Again, this is just one way to visualize. So, I hope you see that there's lots of different ways to look at the data. And again, this is just top level, first level review. And so by bringing, again, my goal today is to really to help you look at some of these key insights that you could then go in and target, because we know you've got your mind elsewhere. And so we wanted to bring this information to you to help you prioritize some things to look at and to consider for deeper dive into the details. Okay. Let's look at the distribution of NTA case mix a little differently here. So here you see in more of a bar chart, and this just has the last calendar quarter. So this is calendar quarter 2 for 2020. And again, you've got your legends on the right so you can see. And here in the red box are the lower 2 case mix groups. And nationally, over 50%, a little over 50% of the assessments are landing in these lower 2. So the difference, and if you look at the legend here and the score range, you see that 1 point and one possible diagnosis or comorbid condition that could qualify could change you from an NF to an NE and go from a 0.72 to a 0.96, or all the way up, from a 0.96 to a 1.34. And again, making that multiplication or that multiplier more impactful. And so even leaving, one diagnosis on the table and not getting that coded can certainly have an impact in your reimbursement. And especially, more than, you multiply that by the number of admissions times, 12 months in a year, certainly can add up over time. Okay, so again, data visualization is important. So how you look at the data, how you lay it out that can provide more insight into what's going on in your facility. Okay, so let's move on to looking at CMS scrutiny and compliance issues. And actually, before we start, I'm going to ask you a question. I'm going to launch a polling question here. So hopefully you see the polling question in your panel. And so if you could go ahead and answer your questions. And so this is about, did you add, are you looking at PDPM, the rate drivers in your compliance plan? Did you update your compliance plan to include the PDPM specific rate drivers? So it looks like we're getting some good responses here. I'm going to give it a minute while you're jumping in there and responding. Okay, about 10 more seconds here. A lot of votes coming in, so I'm going to leave it just a little bit longer. All righty, I'm going to go ahead and close the poll. And let me share the results here. All right, so as you can see, that looks like nearly half of you have added the PDPM rate drivers to your compliance plan, which is excellent. Okay, it's sometimes we don't think about updating our compliance plans, and so very impressive that nearly half of you have done that. And it looks like 8% haven't done it yet, but definitely planning to add. Another 8% don't have any current plans, but that might be something you consider after we kind of finish the presentation today. And hopefully I make a good case for why that might be important. And then 37% of you might not know. Perhaps you're not in a position where that is part of your role, but it's certainly a good question to take back and ask folks that might be in their responsibility or in their job description to be monitoring that and say, hey, look, have we considered this? Because looking at our data, there might be some of these same red flags in your data. And so, certainly if we're seeing it nationally, it's very likely you might be seeing it in your facility or your organization. So it'd be important to then have those discussions and consider, we're going to take a look at this information. Great, thank you for sharing your information. Okay. So I don't know if some of you have been on some of my other webinars, you know that I've used this slide numerous times, and I've had other colleagues in other areas that use it too, but it's worth repeating over and over and over again. So please share it, share it with whoever you need to share it with. This is directly from CMS slide deck from May of last year. It was the Quality Reporting Program provider training that they provided. And here it basically says, given the more holistic style of care emphasized under PDPM, program integrity and data monitoring efforts will also be more comprehensive and broad. For program integrity, we expect provider risk will be more easily mitigated to the extent that reviews focus on more clearly defined aspects of payment, such as documentation supporting the patient diagnoses and assessment coding. I don't know how much clearer they can get in terms of what their intentions are as to how they're going to watch as we transition from a RUG model to a PDPM model, how they're going to be monitoring this transition, right? It's about program integrity, and they're going to be they're basically saying your risk will be easily mitigated by documentation, right? So, again, if you get nothing else out of this session today, it's about going back and seeing, do you have any of these red flags? Does your data look like the data I shared with you just a moment ago? And do we have the documentation to support those changes in our coding? They're pretty dramatic changes. So where is the documentation to support that coding? Okay, and CMS clearly does not want to have a repeat of the RUG model issues, and I think it was John Kane that kind of called it that the RUGs model had somewhat of perverse incentives for that kind of for coding of those minutes, and we know that there were challenges with that in certain areas, and so we have to protect ourselves and make sure that's not what most providers are doing, but it certainly can appear that way in the absence of that documentation. Okay. So again, I underlined that last line, documentation to support the patient diagnoses and assessment coding. So, what if your data looks like the national averages? Everyone's data does tell a story, but you have to ask yourself, is it the right story? It's just like you can watch news on 3 different news outlets, and you can hear the same story, basic story, based on the same data or the same information, but you hear 3 different spins or 3 different perspectives on that same story, right? And so, we all know with our data in terms of how we're looking at it, and we think it's one way, but when we're looking at it through the lens of CMS, who's concerned about repeating of the prior RUGs model, they're going to be looking at it through the lens of much more focus and perhaps more sinister thoughts about what story your data is telling. And so you look at your data and look at the story that your data tells, and do you have the dramatic changes? And if so, why the dramatic changes? So let's consider the cognitive impairment and the depression changes. So just in those 2 areas, these are 2 areas that are specific to the resident interview process, right? And so, is it that we are truly really seeing more cognitive impairment than we did in Q4 of 2019, or excuse me, that would have been Q3 calendar quarter, right, of 2019 versus Q4 of 2019? I mean, that was a pretty dramatic jump. Are we seeing different patients? Where we're most likely that's not the case, but what is? Did we change who was doing the interviewing process, right? A lot of folks talked about changing up maybe a little bit, that might be a good thing. Did we change it? Did we provide extra training on interviewing? Did we really do just an out and out, all facility or corporation or organization wide emphasis on better interviewing techniques, right? Certainly a logical explanation and a very, very valid reason why you might see an increase in that. Okay, we know it's going to be important. So I think CMS is expecting to see some of this legitimately. And now that it's a driver, that maybe these facilities will pay more attention to it. But it's also about quality of care, right? Because recognizing cognitive impairment and recognizing depression means better interventions on our care plan, right? That we're hopefully going to address the care concerns part of it as well, right? So they're going to be looking at care plans. We should be looking at care plans. They're going to be looking at your interview process. So you need to take a look at the interview process. I know here at PointRight, as we evaluate some of the things that come through on our data integrity audit, and we get a lot of questions on our help page where people are always asking, I don't understand why this triggered. Well, what we're seeing is, are we seeing an increase in the number of staff assessments being conducted where there's also a resident interview for a different component? So perhaps their pain was done as a resident interview, but yet the staff assessment was done for the cognitive assessment and maybe the depression symptoms. Okay, so why is that? If they're interviewable for one, they should be interviewable for all. And so it's really important to look at your process. Has your process changed? Is it for the better? Is it, are you really capturing it? Or is there evidence of maybe somebody just kind of getting in there and doing a bunch of staff assessments, which might be easier to get them done? Or perhaps during COVID, you made changes to how you're doing it to decrease the contact, the number of different people that residents had contact with, and now you're seeing an increase. Again, these all could be very legitimate reasons, but they certainly, if you're seeing these changes, this is where further investigation is definitely warranted. Okay. So again, so when you look at this and you see these changes, are you investigating the coding, and are you documenting your research and your investigation and your analysis as part of your QAPI? A lot of times when these ADRs and possibly even these federal surveys or even inspections for potential fraud come through, these are, months and years later, right? And so you need that documentation. Nobody can commit that to memory and understand why these occurred. So again, this is really important to make a part of your QA API process overall. Along the same lines here, same goes here for swallowing disorder and mechanically altered diet. If there are dramatic increases here, again, is it a better process for assessment, a result of increased training? Are you seeing more certain types of residents? Again, this could be possible, certainly, in the latter quarters related to COVID. Maybe we are seeing some changes in the types of residents we see. We know there's been a decrease in admissions from the hospital, decrease in elective surgeries. So surely this is a legitimate, potentially a legitimate explanation for this, but you don't know until you get in there and look. And again, making sure you're documenting this. You've got the documentation to support the coding and the documentation to support your analysis in your QAPI. Okay. So again, let's look, how has COVID changed your data story, right? Have you seen dramatic increases in extensive services? So here I would say, did you code your isolation correctly? There was a lot of questions out there about how do we do this if we're cohorting residents? What if we don't have a positive diagnosis yet, but we have a presumptive diagnosis? And, there's definitely a presumption of COVID according to the physician. If we have this documentation, is that enough? Bottom line, again, this is definitely a question that a lot of folks have had. And I think right at this point, what we have in writing is the RAI manual. And so very important, sticking to the strict coding isolation. We know that we've heard that the cohorting is not a legitimate way to code for extensive services, excuse me. So again, go back and look and making sure, especially early on, if perhaps you changed how you were doing this coding, do you have any that might be coded incorrectly that you need to address, okay? Or at least document and make sure that the explanations are there. Okay. Let's take a look at areas of risk for increased scrutiny in your outcomes. Okay, your quality measures might be telling a different story than you think they're telling, right? And so again, looking at your quality measures routinely, and I know you're challenged with time, with so much going on, but if you can take a look at some of those quality measures, and again, looking at whatever system you use, hopefully you can get in and take a quick glance and see what's happening here. Because one of the things that CMS has very clearly mentioned is that yes, we expect that there probably will be some changes in therapy delivery, but we're going to be watching your outcomes, right? And so looking at this is just one example of that I found in facilities data. And looking at this is the short stay improvement in function quality measure. Okay, and so you see in September, October, November timeframe, they were doing really, really well here. This is an improvement function, so higher is better, and so well above the national average, at 89.8% for their rate and a 69% for the national average. Well, then what happened? In December through February, that tanked. It dropped dramatically to 65.3%. So again, this was pre-COVID, right? And so say, okay, well, what happened? Well, again, in your mind, you're thinking, well, maybe you can explain it one way. But I'll tell you, one way CMS is going to look at this is they're going to say, I wonder if this facility changed how they were delivering therapy services because it wasn't necessarily the payment driver anymore. And they switched over to group and concurrent therapy more, and they dropped the number of minutes that they were doing per resident, just because it wasn't that important anymore, right? I mean, again, that could be the kind of the dark side that CMS might go to, just looking at this data. And again, until they get in there and evaluate, they're not going to know for sure. But again, they might start pulling and saying, we're going to evaluate, and this is a facility we're going to dig into and scrutinize a little bit more carefully. Okay, so again, this is why it's important to be looking at. This was pre-COVID. Okay, right there, you can see the drop. And again here, we got to understand the changes in your outcomes. Here is the Medicare 30-day rehospitalization measure. Okay, and again, this facility might not be too concerned because they're below the national average. This line up top here, this blackish line here, is the PointRight national average. And you see the facility observed and the facility risk adjusted lines are well below. Okay, again, but what you see here in February through May of 2020, you see this really gradual upward trend, and that's not necessarily a good thing. And so you want to watch your trends over time, even if you're below the national average, because then very quickly those things can jump up, and get you catch you unaware, right? And so paying attention is really important, even to those subtle changes. Okay. And and what impact? And I think we're just scratching the surface right now. What impact is COVID-19 going to have to the quality measures, right? We know 5-star, definitely CMS has done the freeze for us in certain ways. That's certainly going to help. But again, once that starts opening up, what's going to happen? But we have got to look in terms of on a month-to-month basis. And again, if you're looking at more real-time quality measures, this is where it gets very, very helpful. And let's be very vigilant, especially on areas of depression and mood disorders and behaviors. That social isolation that we're all going through, but specifically our residents, we're at much more increased risk for this. And then also you could say, if we're starting to see more mood disorders and behaviors, are we at risk for seeing more use of antipsychotics or psychoactive medications, right? Risk for decreased mobility, pressure ulcers, incontinence, weight loss, falls, all of the above, right? And so I think this is what, one thing that we have to be very, um, uh, you know, vigilant on, and looking at MDS accuracy. Make sure you're using your data integrity audit or your MDS scrubber if you've got one, making sure that everything going out, one MDS at a time, is accurate. Proactively monitoring your quality measures, and looking at, possibly did you have other staff helping with MDS during the outbreaks? So this might be even more reason to make sure that you're reviewing each MDS for accuracy very, very carefully. Okay. And again, even if you weren't impacted by the number of folks in your facility that had the virus or have the virus, your residents are certainly impacted by the precautions that they're taking. And I can't even imagine, not having, those family visits. And so we're very, very likely. And again, I think we're just seeing the tip of the iceberg here. Okay, I've got another poll question here for you. Let's see, here we go. So in this one, I'd like to get an understanding of how you evaluate your data story. Okay, so the poll is open here. And go ahead and respond. And so looking at, do you use Casper for your data analysis? So you're pulling down Casper and using it from there? Or do you use something available in your electronic health record? Or do you use a third party? I do know we've got a lot of our PointRight customers on the call today. So do you use a third party analytics vendor? Or perhaps you don't know, you're not in a position where you know that, or maybe you collect it manually still, and that's just something that you prefer to do or your team prefers to do. So again, I want to leave that poll open for a little while here, make sure we've got a good representation of our attendees today. Okay, looks like more coming in. It keeps climbing. All right, it looks like it's slowed down. So I'm going to go ahead and close the poll. And let me share that. Okay, looks like the vast majority of you use Casper to analyze your data. Okay, about 6% use what's available in your EHR. Almost a 1/4% use a third-party vendor. 2% collected manually, and 6% of you are probably in a position that it's not part of your role. But again, this might be, hopefully you'll take back some of this information to help your colleagues in knowing what to maybe focus on during their next review. Okay, and lastly, let's take a look at preventing missed opportunities. There we go. Slide's not active, not behaving here. All right. So when we look at missed opportunities, and when we looked at earlier at the MDS sections, we saw that one.
Hey, Maria, sorry to interrupt.
Yes.
It looks like you are not sharing right now.
Oh,
So
let me. Yeah, my slides are acting a little goofy here. Let me try again here. There we go. How about that?
very good. Thanks.
Awesome. Thank you so much. Okay, so when we looked at the MDS coding sections, we learned that one diagnosis can make a big difference. And one way to thoroughly review a record is to look for particular items, okay? And so perhaps maybe in your next review, consider saying, okay, now we're going to review the diagnosis list and consider what are common comorbidities and complications that frequently accompany these diagnoses. So for example, when we look at, let's say you have somebody that has a diagnosis of ALS or amyotrophic lateral sclerosis, right? But there's no swallowing problem or there's no mechanically altered diet. And you say, well, not all folks have these issues, right? It is a progressive neurological disease, so maybe they haven't manifested yet, but and that is absolutely possible. But by the time a patient, usually gets admitted to the facility, you're seeing a lot of these comorbidities already in place. A lot of those folks try to, and because they tend to be a younger population, tend to stay at home as long as possible. So, but again, it's food for thought that I want to provide you today is start thinking about it from kind of a reverse look, is not just looking for the diagnoses, but also looking for common comorbidities. Same thing with CVA. If it's an active diagnosis, right? It's not an old CVA that really doesn't have any, lingering effects, but we're talking about an active diagnosis of a CVA where there is no hemiplegia or hemiparesis or swallowing problems or possibly even cognitive impairment. And again, that doesn't mean they have to have these, but again, looking at them and saying, if they do, did we capture it? And then flipping that around. Perhaps you have a comorbidity, but you don't have the diagnosis. Okay, you'd be surprised how many times we do see this in our data integrity audit, right? We see these, and that's one of the algorithms that we put every MDS through is looking for these that you have the comorbidity, but you don't have the diagnosis. So diabetic foot ulcer without diabetes, not likely, not hemiplegia or hemiparesis without a CVA or other, likely diagnoses. Again, there certainly can be other reasons for it, but again, cueing you into those common scenarios that are there. Or possibly looking at this from this angle, treatments without a diagnosis. So you had isolation without a multi-drug resistant organism, right? That could be one thing. Suctioning without a trach, ventilator, COPD, or pneumonia, et cetera, right? Looking for those other reasons why that suctioning might be there. Or insulin injections without diabetes. And again, we've seen all of these occur. So, and we know that it's easy to miss these things, right? These are your, especially, as you're doing multiple MDSs at a time, or you had a rush on admissions and you're working through many of them. So these things are very easy to miss. And so again, doing this review possibly as a team or in your weekly meetings can also make sure that you've got the most accurate MDS possible. Okay. And again, documentation impacts the NTA comorbidities, right? Making sure everything's diagnosed, everything you have as a diagnosis are documented. One of the things, body mass index is a good one. If you've got it over 40, check for morbid obesity. And so then, and this is a good one to look at too, because, when you look at how the National Institute of Health defines morbid obesity, they say either 100 pounds or more above the ideal body weight, a BMI of 40 or greater, or the one that a lot of folks don't necessarily realize is they can have a lower BMI, possibly 35 or greater, and one or more comorbid conditions. So let's say they have diabetes or heart disease or other. And so that a diagnosis of morbid obesity could be present on the record, and maybe not realizing it, or it might be somewhere from the hospital where this information is living and you just haven't found it yet. Immune disorders are commonly overlooked. Checking for opportunistic infections, and in that, making sure that documentation, you want to make sure you have the organism in the site. If there's somebody's ventilator or respirator, check for diagnoses of respiratory arrest or cardiorespiratory failure. And then end-stage liver disease. Go back and look and see if there's any evidence of cirrhosis of the liver, okay? But it's important to really look at these and know which diagnoses qualify. Okay, here's an example of the of the NTA component and the ICD-10 codes that qualify. You know, there's several codes that are available, but again, if you go to the mapping, the ICD-10 mapping that CMS provided to us early on, right? And here's the link where if to get to that, if you have not seen that, and use filters. You know, filter out by morbid obesity and seeing where they stand. And here you see. We've got E codes and Z codes, and the obesity due to excess calories right here. And these are the ones that qualify for the NTA component. Okay, if it's anything else than this, then it will not qualify. Another really good example of this we see very frequently on our with our data integrity audit is that, oh, I have R13 coded on MDSI 8000. Why did I get this trigger in the data integrity audit? Well, R13 has to do with signs and symptoms involving digestive and abdominal disorders, right? So it's a different category. But see, if you go again back to that mapping, that crosswalk Excel spreadsheet that I just showed, if you look here, the only diagnoses that qualify for the SLP-related comorbidities are the I category, I69, which is under cerebrovascular disease. Okay, and so these are the ones that you have to have coded in I-8000 to get that comorbidity. Okay, so very, very important, and we see this quite frequently. You know, looking at ways to capture swallowing problems. You know, a lot of folks just rely on the documentation, so as if they have an existing swallowing problem, or hey, you know, we've got a diagnosis, that's all we need. But really, you know, this particular area is based on section K 0100A. And so, you know, a lot of times folks are coming in, if they come in from the hospital, they're debilitated, right? Especially if, you know, if they're coming in from, you know, from the hospital with recovering from COVID, they're going to be very deconditioned, right? And swallowing can be a real chore and just very exhausting, right? So you might see, and so this is where CNAs are going to come in very handy and looking for these symptoms. Did you notice any losing of fluids when they were drinking, either liquids or solids? Are they, when you take them back to the room, have you found, you know, food remnants still left in their mouth? Maybe during meal pass, asking all 3 shifts, or if you're giving meds, are they choking when they're trying to swallow their meds, or sputtering at meals? You know, yes, there might be complaints of difficulty swallowing or pain, but you know, this is usually something I don't know. Remember that I heard this a lot. You know, patients, this isn't something they complain about frequently. They may just realize this is part of normal, or they may not even realize they're holding food in their mouth. So watch several meals, observe, screen residents, and watch for changes over time. Just because they didn't have it when they came in doesn't mean they're not going to have it going forward. Okay. And again, diagnoses, active diagnoses, I think folks are getting much better at that. Second bullet here is really important. Use your checklist first. Some of the NTA diagnoses only count if the checklist item is checked. So a good example of this is diabetes at I-2900, okay? You can say, oh, I had it coded in I-8000. But it's no, this is really important that it be coded as CMS shows us of where they're pulling them from as well. Okay, and so if you have any questions, refer to the RAI manual, chapter 6, and there it's all laid out there. And again, going back to that ICD-10 Excel spreadsheet, the crosswalk, the mapping, you'll be able to see that very easily. Okay. You know, when you're looking at depression symptoms, you know, look at the end splits, you know, and see, look at the financial impact here. These affect 3 case mix groups for nursing: the special care high, special care low, and clinically complex. And if you look over to the right, you can see the difference that depression will make. And so if you're missing out on somebody that does have depression, you know, you're looking at a difference of $42.37 per day for this first special care high, right? And it goes all the way, it ranges all the way from $14.83 to, looks like 42 is the highest here. So that's a pretty big range, and again, that adds up over time. So definitely something to make sure that you're accurately capturing depression. Looks like everybody's doing a lot better with it, but again, making sure that you've got everyone that should be recognized as having these symptoms, and making sure that the care plan shows those interventions. Cognitive and mood interview, best practices, right? Looking at different ways. Speech language pathology can give you guidance on good ways to communicate with residents. If they have a communication deficit, but they're still understanding, and in B0700 and 800, if you're still coding that they have methods and can communicate effectively and do understand you when you're talking to them, making sure that when you're doing the interview, even if, let's say, they can only answer yes, no questions, that's where the cue cards come in handy. And all these alternate methods of communication are very important, because really CMS, our charge, or our challenge from CMS is to capture resident voice, not what we think the resident voice is whenever possible, right? So everyone should have this attempted. And so looking at alternative ways to communicate with those residents that might have challenges. Social services can certainly help us with some guidance on interviewing techniques. There's some great videos that are put out. I put resources on the last slide that have links to those. So if you're new to these or need a refresher, these are great resources. If you're in the MDS world, if you're the coordinator, you're the expert in the REI manual. You be the expert for the rest of the interdisciplinary team and make sure that they're following all the REI manual instructions for the resident interviews and the staff assessment that are in Appendix B. And make sure that the assessor knows the assessment reference date so that interviews are done timely, right? This is another key area that I know a lot of folks struggle with, is getting them done timely. And again, under missed opportunities, another area to look at is your IPAs. This is involved where there's at least a change in one component so that a resident would be classified into a different case mix group from the initial Medicare assessment. And so it's important to know that not every change in a resident's condition is IPA worthy, right? You have to understand the payment drivers in each of the categories that were captured in the initial assessment and consider, is this going to change the case mix group and warrant an IPA? Well, again, which could mean, if you don't look at them, this could be a missed opportunity. Again, don't forget the emergency room visits. If treatment's given during an emergency room visit of less than 24 hours, right? If they're in there real quick for observation, even if the resident wasn't, especially if they're not admitted to the hospital, right? Which is a key point to point out here. These count as while a resident. So they may qualify an IPA if the criteria are met. So look through that. Look through the documentation from the ER. Was there a transfusion? Did they have IV meds or IV fluids? Did they do suctioning? Was oxygen provided? All of those things are important things to look at that may certainly impact the case mix group. Okay. So let's do a couple of examples here. I know we've just got about 10 minutes left here, but let's look at, just to quickly go through these. So if you have a nursing case mix group is currently special care high, and they develop pneumonia with fever on day 12. Okay, this is certainly a scenario that could be happening now, right? Would this, be worthy of an IPA? I don't think so. You would not have a change in the case mix group because the pneumonia and the fever still is in that special care high category. Well, let's say that you did a COVID test and they came back positive and now you need to put them in isolation. This would definitely change that story, right? Okay, so there's certainly an example of something that could happen today. So let's look at this one. This one where you have an NTA with a case mix group of ND. The score is 5. We've got COPD, diabetes, and morbid obesity. And on day 8, you see a diabetic foot ulcer. It's documented, it's identified. And you say, okay, is this something that is IPA worthy? Yes, this absolutely could be IPA worthy because it changes the NC group, changes the case mix groups to NC from ND, and therefore, because the score is now 6, so certainly changes that and could be IPA worthy. Let's look at a last one here. A PTOT case mix group is TF, where you have a function score of 7. But by day 7, the mobility has definitely improved to their partial moderate assist, they transfers, and walking with substantial assist, okay? It's on day 7. And so you say, okay, is this IPA worthy? Yes, why is that? Well, this would change the case mix group to TG. You'd have a new function score of 10. And the PT and OT variable payment adjustment is not in effect yet, right? We're on day 7, and that doesn't go into effect until after day 20, right? So definitely this could be IPA worthy. Okay, so like I said, as I mentioned earlier, the references to the websites I referred to. Again, the first one is where you can find that ICD-10 crosswalk. If you're just not sure about the diagnoses, you think you have them coded right, and you think it should qualify for a particular case mix group, but yet it's not showing up that way. This could be a good resource for you in terms of why that is not triggering. And again, if you're a PointRight customer, that's something we provide for you in our data integrity audit. We're giving you those PDPM reimbursement alerts. And so watch carefully for those, because a lot of those same things that I shared with you today are covered in those alerts. Here's CMS training videos related to the training materials, and the mood assessment and the videos for interviewing vulnerable adults. Again, these are great resources that, especially if you have a new interviewer, and go from there. Okay. Oops. Next slide. Come on. There we go. SurveyMonkey. Here's the information related to your CEUs. We're going to be emailing you a link for an evaluation. And so you can either use that or go to the SurveyMonkey we provide here. We need your survey due by next Friday, so you have a week to complete that, but we definitely encourage you to get that in as soon as possible. You see the attendee each attendee must complete the survey to receive the credit, and you can use the forward to a friend link at the bottom of the evaluation to send to other attendees if somebody's in there joining you. Certificates will be available for download after completing the survey, and then you can see that's for nurses, and then for the nursing home administrator, and NAB ID, and actually we'll get that for you, reporting that we can report to the CEU registry. Okay. And actually, I've got one more poll question that I'd like to ask you before we go to the questions. And again, go ahead and be putting your questions in the question feature here. I'm going to go ahead and launch this one. We're very curious. You know, now that we're in this new world of COVID, we're really anxious to see of how you feel about the virtual conferences. You know, how do you plan on attend? Are you going to attend a national show? At least one? Are you going to look at possibly going to the state shows? Or maybe you're going to go to state and national. You really like you're going to look at all of them. You like the virtual approach because now you can go and it doesn't cost you anything, right? Or very little, I should say. You don't have to worry about the travel costs. And then, or you just don't see value in any of the virtual conferences, so you're not going to attend. So again, that'll give people time while you're doing that. If I'll take a look through the questions and answers and see if there's anything come through. Looks like we have one question here. It says, we're seeing increases in our depression rates too. Is the documentation in our QAPI going to protect us from the compliance issues? You know, that's a great question. You know, but I think it's certainly going to help, but what's going to help you most is on each individual resident who's coding, you know, that you're coding with depression. The documentation to support your coding is going to be what's going to be the most valuable item, because that's where CMS is going to look, right? If you have an ADR, they're going to look and see on each resident one by one, does this record show evidence that this is accurate coding? And so very, very important place to start is in each individual record. Your overall documentation in terms of if you're seeing as your response to your trends, that's going to help you just in your QAPI process. And again, the documentation that you looked into it, you evaluated it, and therefore you can explain it even months and, you know, potentially even a year to 2 years later, if the need should arise. Great question. And here's another one. we changed who was doing the interviews for PHQ-9, and now we see an increase. Was that a mistake? And no, not necessarily. And again, just to reiterate, this happens. I mean, it could be a very legitimate reason for seeing increased depression. Could be COVID related, and a lot of folks have changed because they have nursing doing it now because they just wanted to decrease the number of folks that were coming in contact with the residents. Again, document, document, document. If it's in the record and it supports what you coded, you really have nothing to worry about. Each individual resident is going to be your best defense, right? Again, so dig deeper though and look and see, are more staff assessments being done? We have noticed that. So, just again, that's very anecdotally, noticing that there are some times where that looks interesting and worthy of analyzing further. So we encourage you, when you see those kinds of patterns, make sure that that's appropriate, or there's a really legitimate reason. If we can use staff interview for swallowing problems to code, how do we substantiate proof for the interview? I think everything is about documentation, right? Listing, they observed, on several occasions, right? Whether you have, perhaps you look at questions in your EHR, developing, if you have user-defined questions for your CNAs and their point of care systems. I know some folks will document, especially initially, are you noticing any of the following symptoms? And they answer those questions at various intervals, and then that way you've got your documentation. And again, that can go back and report. The nurse can report what they information, the observations of the CNAs and other nurses, that could be documented in the system. But again, it's resident by resident. That's really important. Somebody says, since COVID, I see a decreased, cognitive abilities without the visiting and peer stimulation. Oh, that's so true. So true. Definitely something we want to be watching for. Thank you for sharing that. Okay, and I see we have more questions coming in. Keep them coming in. But it looks like our time is up. I'm actually 1 minute over, and so we will go through the questions and make sure we respond. And just like we did last time, we can put these out there so for all to see, and again, get these responses back to you, because I know these are great questions, and I know I threw a lot at you over the last hour, but hopefully, we wanted this to be helpful, to give you areas where that you can focus and just pay a little special attention to, and making sure that you're keeping up with the story that your data is telling. Thank you so much for joining me. It's been my pleasure chatting with you today, and we wish you the best of luck.